I'm a full-time firefighter paramedic for the City of Alpena Fire Department. Just kind of let you know where I work at. So anything that I'm going to be talking about on this clip about patient assessment and management is going to be more geared towards real life, but also mostly I'm going to be going through the National Registry skill sheets. I was requested to kind of make a video about these so that people that are taking any EMR or MFR class, they kind of have a little bit more guidance versus just what the book tells them. And ultimately, especially here in the state of Michigan, you are tested to the National Registry standard. So I figured, why not? I'll just kind of base this whole presentation off of the National Registry guidelines and the national standard. So as you can tell here, this will just be a simple video just going over patient assessment and management for the EMR, MFR student for both the medical and trauma. So just a little introduction to myself. Like I said, full-time firefighter paramedic. I work for the City of Alpena Fire Department. I am doing this video independently from them, though. This is just me doing this on my own merit. I'm not doing this for any pay or overtime. This is just me doing this just to kind of help out people that want the extra help. New perspective. There's a picture of me, as you can see. Been a firefighter since 2010. EMT since got my EMT in 2011. Paramedic became in 2012, and since then I got my critical care paramedic in 2018, and my instructors, I say that because it's a fire instructor in 2018, EMS instructor in 2018 as well, spring and fall, just conquered them both in 1 year. And also my education background, more in depth, obviously I have a high school degree. I have a bachelor's degree in fire science, paramedic associate's degree. Went to Lake Superior State University from 2008 to 2013 when I acquired those things. Very good time up there. So I'm a first generation firefighter paramedic, so that's why I went to college for it. Very glad I did. So now I just have more experience to kind of share with you. So let's kind of get this rolling. Big time disclaimer though, like I said, for this, this material does not follow any specific book or published materials. This is me sharing my experiences from doing patient assessment over the years of being an EMS provider. And I'm more gearing this towards the EMR, MFR level. So that's all this is. I'm not following any book. This is meant to help create your own flow and help memorize the National Registry Patient Assessment Management for the medical and trauma psychomotor examination. This is just to help you. That's it. I emphasize, did not receive any payments or endorsements for this specific presentation. I'm just kind of, like I said, I'm doing this on my own merit, just because this is especially one topic that I've noticed I have struggled with many students, especially if they're new to EMS. This is just a whole new realm of EMS to them compared to just doing the everyday skills. This is actually the big stuff, the assessment stuff. So this is the most traumatizing and most intimidating to students. So that's why I'm doing this on my own merit. Ultimately, follow your own local protocols and department standard operating procedures and guidelines, because that's going to depend everywhere you go. I'm basing this mostly off of Michigan, just because that's where I'm located. The National Registry of Emergency Medical Technicians, so NREMT, Emergency Medical Responder, EMR. I also say MFR because here in the state of Michigan they still call them MFRs. Psychomotor examination sheets will be used during this presentation. I have them right next to me. I'll be reading off of them for you guys. I assume no liability for how you use or apply this material. So how you use this and how you apply it to your life is your own decision and choice. I am not responsible for what you do in the field for this presentation. I overemphasize that because I understand, yes, I am a licensed instructor, but I'm not doing this for pay. I'm not doing this for a big corporation. This is just me being a good person, just trying to help out others remotely, because especially during this whole coronavirus thing, I can't do person-to-person interactions as well, so I have to kind of adapt and improvise so that I can continue to help people when they want the help. So this presentation is made for helping those that are new to the EMS field with helping memorize and learn potentially different methods for how to assess patients for both medical and trauma-related emergencies per the NREMT standards. So I am following them. This is nothing new. You can access all this stuff online on their website as well. So I'm not teaching or doing anything different or changing their standards. I'm just going off of what they provide us. So to kind of get the ball rolling, why we need to assess our patients. Well, assessing our patients helps us as EMS providers figure out what is wrong with the patient. It's more than just why they dialed 911. Obviously, if we just went off of why they dialed 911, there would be a lot of questions up in the air. There's a lot of gray area for that, and God bless our dispatchers. They do a wonderful job overall, but they're not there seeing what's going on. They're just going off of what's being told to them. So that's where we come into play, where we get dispatched for a whatever situation. They tell us what they got for information, then we arrive and we start putting the puzzle together. We're there to figure out what is wrong. So we as EMS providers do not just apply oxygen, take vital signs, and do CPR compressions, especially at the MFR and EMR level. I cannot overemphasize that because a lot of people give the initial level of EMS providers a very bad rap, and they're very hard on them, in my opinion. That's not the case. In my opinion, as EMRs, MFRs, you are the starting ground for the EMS pyramid, as I'll call it, or the chain of survival, I'll call it, as the AHA says for their CPR stuff. You are the foundation to this. You start it. You do the initial care while you're either waiting for ALS or for a better outcome for that patient. You start it. You are that important for these people. So you're more than just, as my next point, we cannot just, well, that's not next point. I'll get to it in a moment. But we cannot just treat a patient blindly either. We could hurt or kill a patient or impact someone's life negatively. So we're not just there just to do what they ask us to do. We're there to treat them, to help them, to potentially get them feeling better. Care does not just happen in hospitals. People need help now. That's the whole point of 911. They called us because they need help right now. There's an emergency right now for them. And obviously, I throw this in here. We do not get a license just to wear a t-shirt and get discounts. When it's time to do our job, be ready. That is one of my personal pet peeves, is when people join a department just for the perks of it, not for the actual job of it. Don't join something just so that you can be, I'll say, to be honored and to be worshipped. That is not the point of this profession. So if you're getting into this profession and volunteer world for that reason, please just spare everyone the expense. Just don't even bother. Again, that's my opinion, like I said earlier. I'm able to say that on this because I'm not representing any department right now. I'm doing this on my own. So, to kind of get the ball rolling for the patient assessment, so the National Registry Emergency Medical Responder Patient Assessment Medical is what we're going to go through first. I got to get my medical sheet out here. So here's just a little snapshot picture of what it looks like. I know it looks like that there's a lot. There's a total of 40 points, as you can see, from the top to bottom, and there's critical criteria. But don't worry. I remember when I first saw these sheets for the first time, these sheets were very intimidating to me. But over time and with practice, it actually gets a lot better, and it makes sense why it looks so cluttered, why there's so much on here. So the patient assessment sheets are updated and changed regularly, so always stay up to date with these. I just pulled these today off of the National Registry website, so this is the most current sheet that I will be using. It says the last time that they were updated was 10 of 16, so I wouldn't be surprised if in the next year or two that National Registry will be updating these and changing them. That's just what they do. So just always be mindful that they are always changing. The best thing for this sheet is just to memorize this sheet. Don't try to figure out a shortcut. Don't just memorize part of it and think that the rest of it will fall into place. There's no easier way except to just memorize what you need to know. Repetition. It's almost like learning how to count, learning the ABCs and all that stuff for children. It's that repetition. It's the same thing for this. Because when you start repeating this, practicing this, and applying it, it's going to fall into place a lot more easily, and you're going to see how it transitions into the real world. Why, if you practice in this order, it's going to actually be a lot better for you in the long run, because you're actually formulating a very good response and a flow for you as an EMS provider. So just be aware of the critical criteria on the bottom. That will be automatic failures if you do one of them. Example, you miss a step on the listed steps. I have a little arrow pointed down there. I don't know if you can really read them too well on there, but I'll just pick the second one down. Failure to take or verbalize appropriate PPE precautions. So that very first step where it says take or verbalize appropriate PPE precautions, if you don't say that, that's an auto failure, and The proctor will let you go through it, but you just failed the entire station. So just be very careful that critical criteria. Know about them and remember them. And that's why I say just memorize the sheet, because if you memorize the entire sheet of the point value, you're not going to hit a critical criteria. In my opinion, it's easier just to memorize what you should know versus memorizing what you shouldn't do or should not know. You'll have 15 minutes for this whole sheet, so you will have lots of time. Initially practicing for this, it may take you longer. That's okay. The more you practice, the faster it's going to go, so that's no big deal. 15 minutes is lots of time. And here I have NREMT.org on there, EMR certification. That's where you will find this sheet. So for every first step, always take or verbalize appropriate PPE precautions. Every National Registry sheet has this as their very first step. It is very important. Do not forget this to take this step before starting any, especially this station. This is an auto fail. It's the second one on the critical criteria. So just remember it when you're doing your skills sheet, your practical day for it, your final checkoff. Just remember, just automatically the first thing you do at that station, PPE. I'm gonna don my PPE. I'm gonna put on my appropriate PPE. Boom, you got it. You're taken care of. Then scene size up is right after that. So you're going to determine the scene situation, determine the scene and the situation is safe or not. So you're going to ask the question out loud to the proctor and wait for the reply. You cannot do anything until the scene is safe. This is an auto fail if missed. And I can't remember exactly which number it was on here, but it is on there. Anyways, I'll find it later because I know it is on there. It's an auto fail, so just remember that if the scene is not safe, you should not be entering it. And so when you get there, I have my PP on. Is the scene safe? Yes, the scene is safe. You may proceed. Okay, boom. So now you can go in. And then next, you're gonna determine the mechanism of injury and nature of illness. Most likely for the medical, it's gonna be the nature of illness. They could be injured from a medical emergency, such as, like, say they had a syncopal episode, passed out, and they fell, which gave them a golf-sized bruise on their forehead. That's secondary to the syncopal episode. So figure out what happened first, such as, okay, you see a patient pass out on the floor. Okay, they're passed out. That's the nature of illness. They had a syncopal episode. But now why? So at this point, you're probably going to start requesting additional EMS assistance if necessary, especially at the EMR MFR level. I know here in Alpena County, paramedic unit is automatically dispatched the second that the first responders are. I know a lot of places, not just in Michigan, outside of Michigan, are like that too, which is very nice. But you're gonna want to state that you're going to request additional EMS resources for the situation. You're going to state that out loud so that your proctor will hear it. You're going to say, at this point, okay, so I have a patient that is passed out. I'm going to request for ALS ambulance if one has not been dispatched already so that I can get them rolling on the way. Just get them coming. And if anything, you're also going to consider stabilization of the spine. Even for a medical call, it's important because until proven otherwise, you must verbalize your thoughts on this. Like, you must say, I'm considering stabilization of the spine. Whether it's a patient having chest pain or not, you're going to say, okay, if this is chest pain, non-trauma related, they haven't fallen, I don't need to worry about stabilization of the spine. Okay, boom, you got that. Great. If it's a syncopal episode, you might have to say, okay, syncopal episode, don't know which came first. I'm going to consider stabilizing the spine. I'm going to have a partner hold neutral inline position, which ultimately leads to the trauma assessment. But you're going to say that just to kind of express your thought process to your proctor. That's why that is there, because people can still get injured from a medical emergency. So maintaining stabilization of the spine is very important, because if you don't, you can also hurt your patient that much more. So that's why that step is there in the scene size up. So main takeaway for the scene size up, this can easily be completed in 1 minute. It goes much faster than you realize, and don't question that. Like, don't question yourself about that. It really does. Don't second guess yourself. Just when you actually start doing it, you'll start to breeze right through it. And the first five steps must be completed before you make your initial patient contact. So just remember that. You do this first 5. Okay, I'm showing up on scene. I'm going to put on my PPE, don my appropriate PPE. I'm going to determine, is the scene safe? Yes, the scene is safe. Okay, there's my patient. My patient is sitting on a chair, conscious and breathing, and I was dispatched for chest pain. Okay, so that's my nature of illness. I'm going to request additional EMS assistance as needed for this. It's chest pain. I can't do much for chest pain, so I'm going to call for an ALS ambulance for continual care for this patient. This patient doesn't seem to have fallen. There's no signs of trauma or reason for injury to the spine, so I'm not going to worry about stabilizing the spine. Boom. You're done. See how fast that took me? It's very easy just to kind of roll through those 5 steps. Don't forget them. They're important, but it's very easy to get through them. A lot easier than what a lot of people think. So don't second guess yourself. Just do it. So now your primary survey, resuscitation is what they call it, or your primary assessment. That's the old school way of saying it, I guess, according to this, because they have secondary assessment later. I'm just going to refer to it as primary assessment because that's how I was taught and remember it. So after you get your scene size up taken care of, you're going to determine the responsiveness or level of consciousness for this patient. A nice little mnemonic called AVPU. And what it stands for is basically you figure out what your patient's mental status is at this point, and also level of stimuli if you have to provide any, or if needed, for this patient. So AVPU, A, alert, V, verbal, P, painful, and U is unresponsive. So obviously they're alert, they're looking at you, they're talking, they're able to tell you, I'm having chest pain. Okay, so the level of consciousness is they're able to talk to me. Great. Or are they kind of slumped over in a chair and you say, hey, Mr. Smith, and they wake up? Okay, so now they need verbal stimuli to maintain their consciousness. You have to continue to talk to them to keep them awake. Or they're slumped over in a chair, you talk to them, no response, you give them a sternal rub, or you touch their eyebrow to do the, I don't want to say painful stimuli for an eyebrow touch, but a sternum rub especially, but you do a physical touch as a painful stimuli, and they start to come around with it. Okay, now they need a painful stimuli to be, I don't want to say alert, but to be conscious. And usually those patients go back to an unresponsive state relatively fast because you can't sit there and continually do painful stimuli on them. You yourself won't be able to finish your assessment, plus you're not going to sit there and just continue hurting the patient. You're going to figure out, why is this patient only responsive to painful stimuli? And you have your unresponsive or unconscious patient. It's pretty self-explanatory. They're just not responding to anything. This is not that they're dead or it's a full code. It's just they're not talking to you. They're not responding to anything. They're breathing, able to maintain an airway necessarily or not, but they're able to breathe. They're just not awake, essentially. So you're going to determine the chief complaint and any apparent life threats that may be present at the time. So what is your patient complaining of? It could be an unknown medical and you get there. Sir or ma'am, what's going on today? Well, what made you call for the ambulance? Oh, I'm having chest pain. Okay, boom. They're having chest pain. I know a lot of times a lot of patients will get caught up with, let's say, multiple complaints. Figure out what their number one complaint is and why they called EMS initially. Such as, well, I'm having chest pain, but I'm having difficulty breathing and I'm dizzy. Okay, well, what started first? Well, my chest pain did. Okay, is that your biggest complaint right now out of the 3? Yeah, because it started first. When the chest pain was there, then the difficulty breathing started, and then the dizziness started. So you're going to figure out, okay, we're at chest pain now. Now you can start formulating your care plan down the chest pain once you get further along the line. And what is life-threatening? Is there anything that's life-threatening that you see on your patient at this point? Is there anything that's going to kill the patient, or is this patient going to severely deteriorate rapidly in front of you? If so, you need to address that right away. That's why that is there, because now you're leading into your ABCs, where you're going to have your airway and breathing. Your medical assessment kind of combines airway and breathing into just 3 simple points. So you have your assessment, your adequate ventilation, and initiate appropriate oxygen therapy. So basically what it comes down to is, what do you see? So you're assessing your patient. What do you see? Do they need your assistance for breathing? Are they able to breathe adequately or enough on their own? Do they need you to do something? And what type of oxygen therapy are you going to use for them? Whether it's a nasal cannula, it's going to be a non-rebreather, or a big valve mask. Usually those are your first 3 go-to tools for the MFR and EMR for your airway and breathing, especially for a medical call. on the National Registry sheet, there are 3 separate points. You have your assessment, assures adequate ventilation, and initiates appropriate oxygen therapy. Those are 3 separate points, so make sure you hit those 3 points for your airway and breathing part of this survey. Then you have assess your circulation. So you're going to assess control major bleeding. Is there any bleeding? Do you see any bleeding? Usually for medicals, not necessarily, but there are medical reasons why patients do bleed, such as a GI bleed, or you can have a stoma that they just had a fresh stoma and that's bleeding now, or if they have scabs from whatever medical treatment, especially diabetics, where they have slow healing wounds on their legs or weeping wounds from pressure sores and all that stuff, where they can bleed out. So there are medical reasons for that. And do you need to control that bleeding? Is it bad enough that you have to do something, or is it controlling itself? You have to verbally say that, where I'm looking for any bleeding. Is there any bleeding, as I have on there? No, there's no bleeding. Okay, good. Now you can check your pulse and also assess your skin, which is you're going to check the condition of the skin. What does it look like? Is it pink, warm, dry? Or is it pale, diaphoretic, cool? Does it not look right? Does it not feel right for the patient? Their skin color tells you a lot. So that's why skin condition, temperature, and color is actually very important. And on the National Registry skill sheet, the assess control major bleeding, checks pulse, and assess the skin. Those are 3 separate points as well. So make sure that you hit those 3 points when you are doing your circulation assessments. Pretty self-explanatory up until now for each step, just because it kind of walks you through. So you think airway, breathing, circulation. Okay, I gotta check my airway. Are they breathing? Do they need intervention? How are they breathing? Boom. You just have your airway taken care of. Your circulation. Well, is there bleeding? Yes or no? Okay, check a pulse. They have a pulse. Good. Their heart's ticking. What does their skin look like? Pink, warm, and dry. Okay, cool. You have your ABCs taken care of that fast. So again, this is very fast as well too, naturally. I'm not saying that you have to go for speed, but the more you do this, the more you practice, the faster it gets, especially when you practice on each other. And at this point, you're going to identify patient's priority and make treatment and transport decision. So after assessing the ABCs, how critical of a patient are they? Do they need to go now, such as the second a transporting unit gets there? Or is there time, such as that you can do more of a detailed assessment, or that you can do more interventions, and while your higher level of care ambulance gets there, whether it's a BLS or ALS unit, especially from the MFR level, are you able to do more and help out more on scene and stabilize that patient before you get them out of the house and in the ambulance and down the road? So you have to remember that. What decisions are you going to make with what you found? So this is a critical point, and it's a very easy point that's missed because it's a very thin line right underneath circulation that a lot of people miss. And like I said, out of my years of doing this, a lot of people forget this step because it sneaks up on them. But you have to determine a patient priority and your treatment and transport decision. You have to verbally say, okay, they are a higher or lower priority, or a priority 1, 2, 3, depending on what system you use. And what decision are you going to make with what you found? Such as, okay, they're having chest pain, they have pale, clammy, diaphoretic skin. When that ambulance gets here, they need to go now for a higher level of care. Or now they're pink, warm, and dry, their pain level is low, it just started, they have home health care there, or they have medicine there because they have a history of chest pain, let's say, so they know what to do, they're stable. Okay, you got a little bit of time. So at this point, you have to determine that. So now you get into your history taking. Not quite your secondary assessment yet, but now for especially your medical calls, you're going to have this mnemonic called OPQRST. I love this mnemonic because it's actually great. So O is onset, P is provocation, Q is quality, R is radiation, S is severity, and T is time. So onset for this is, what were you doing when this started? Ask your patient that. What were you doing when your chest pain started? And you're going to ask that to the proctor, especially for your National Registry skill station, and they have a scripted response for you. Provocation, so what makes it worse? What makes your chest pain worse, for instance, let's say? Or better yet, what makes your chest pain better? Is there anything you do make it go away? So you have provocation and provocation. So you have your opposites there. So cover that. What makes it better, if it does, but also what makes it worse. Quality, what does it feel like? How would you describe what you're feeling? So chest pain. Tell me, what does your chest pain feel like? Is it and let them answer. Don't answer for them yet. If they don't understand what you're asking for what you're trying to get here, then you can start saying, okay, does it feel like a dull, aching, sharp, stabbing pain, pressure, elephant on your chest, can't catch your breath? All of those questions is what quality encompasses. Radiation. Does the pain go anywhere else? Does your complaint affect anything else? So especially for chest pain, does your pain go anywhere else? Does it stay in your chest, or does it go anywhere else in your body, to your left arm, to your left neck, to your head? Abdominal pain is another one. Where else does the pain go? Where else did the pain start? Anywhere else? Where is your pain at now? And such as, does it affect anything else, especially for migraines? I feel bad for people with migraines. Obviously, you can rate the pain on a migraine, but is it affecting anything else? Are they feeling nauseated? Do they want to vomit? Are they dizzy? So that's kind of what radiation encompasses. Then you have your severity. So your 0 to 10 scales for pain, difficulty breathing, what they are feeling. Have them rate the intensity of their complaint. So pain is obviously an easy one. 0 being no pain, 10 being the worst pain ever. So that's what severity kind of comes into play, especially difficulty breathing. Same thing. 0 is very easy, everyday breathing. 10 is the worst time you've ever had breathing. You can use it for comfort, such as, especially if they're having numbness and tingling. It's kind of a stretch, but you can ask them, can you feel some light numbness and tingling in your lower legs, or does it feel like that there's a complete disconnect of your lower legs from the rest of your body? So that can all be severity encompassed. Then you have time. How long has this been going on? And that's very important, especially for pain, because you want to figure out how long they've been experiencing this and suffering through this. Because you want to make them start feeling better, but also it can tell you how serious this situation could be right now. And then you have your clarifying questions of associated signs and symptoms related to OPQRST. So what other pertinent questions can you ask? That's basically what they're getting at here at this point. Clarifying questions such as if they're confused. Quality is one that a lot of patients get confused with, especially for radiation, where those are the two that you may have to explain a little bit more than normal, kind of get to their level of understanding for it. Obviously, you're not going to say, well, what provokes your pain? No, you're going to say, what makes your pain worse? What makes it better? You're not going to use that P word necessarily. And if you say onset, they may think time. Not necessarily. So you might have to explain these to people a little bit more. And that's not their fault. They don't know. So you need to be patient with them. And you have to understand that. Remember, they're the one that's having the emergency, not you. So they're going to be more worked up than you are. And that's okay. And now you're going to get into another mnemonic. You're going to have your sample history. So you're going to have your signs and symptoms. Sample signs, symptoms, allergies, medications, past medical history, past pertinent medical history, last oral intake, and events leading to present illness. So basically your signs and symptoms, what are you noticing and what are they telling you? That's what that means. Because what you can be seeing can be something totally different from what they're telling you. And that happens sometimes too. Like say someone is in extreme pain and yet you think, well, their heart rate should be up, but their heart rate is, let's say, 60. Well, they could be on medications that makes their heart rate stay low and may not be able to express the pain as much because grandpa's been taking this medicine to help keep his heart rate slow, so now he can't fully show his pain, but he can tell you what he's feeling. Strokes is another one where people are going to say, I can't feel my left arm. They may be able to move it, but there's that disconnect. So there's always that difference between what you see and what they're telling you. One does not trump the other, but it helps you put the puzzle together of what's actually going on. Allergies, what are they allergic to? Seasonal to severe allergic reactions. Allergies encompasses everything, from the small reactions to the most serious reactions. Medications, self-explanatory, what do they take daily or as needed for medicines. Past pertinent history, this is another one that a lot of patients get confused on. Don't necessarily ask ask these patients this question, such as, well, what's your past pertinent history? They're not going to know what you're asking. So what you're going to be asking the patient for the P is, has this happened recently? What other medical history do they have? Do you have history of diabetes? Do you have any respiratory problems, other cardiac problems, seizures, strokes, substance abuse, such as alcohol, illicit drugs? So that's where you start getting into your other, as the hospital puts it, comorbidities or just other medical problems that can piggyback off of this going on. Last oral intake. So when did they last eat or drink? And that's important because especially for a diabetic, you need to know, because if their sugar is super high and they say, well, I ate yesterday, something's not adding up for them. So they're having a true diabetic emergency versus they're having a low, they ate 4 hours ago, took too much insulin. Okay, so now you kind of gauge that their body just ate up all their reserves, which does happen. Or let's say they're having chest pain, and all of a sudden you hear that they're having a heart attack, and it's similar to what they had before for a heart attack. It's important for surgery to know, especially because in order for some patients to have surgery emergently, they still have to wait 8 hours to get into an OR room, depending on what the procedure is. So getting that last oral intake is a very crucial question, especially for depending on the medical call that you're on. And events leading to present illness. This is kind of similar to onset, but not fully. So what was going on before the problem started? Not just what did they do, such as, so if Mr. Smith is having chest pain and he says, well, I was just sitting down watching TV and all of a sudden my chest started to hurt. Well, what else did you do? Such as, what did you do before you watched TV? Did you do anything while watching TV? Because they can just think, well, I was just sitting watching TV. Well, maybe they actually bent over to pick something up because they dropped something, or the little lap dog jumped up on him, startled him, or maybe he was asleep on the couch, woke up abruptly, and started having the chest pain. So that's kind of the difference between events leading to present illness from onset. It's very easy to get those two confused, but there is a difference. Was sent on a call, so now I'm picking this up back 2 days later. So if there's a little gap or pause between the secondary assessment and the last slide, I'm sorry about that. Don't worry about it. I am back to kind of continue on this little video clip. So on a secondary assessment, so basically what you're going to start doing at this part is you're going to be assessing the affected body part. I like how they actually have that worded, body part and the body system that they're usually complaining of. So it's not so much saying that if we continue with the chest pain example of you just do your OPQRS and your sample history and you're done. No, now you start asking your more in-depth cardiovascular questions, like what detailed questions can you ask in regards to the specific body part or system. So again, example for cardiovascular, so you already did your OPQRSD, you can ask them, has this ever happened before? Have you had a heart attack? Is this a similar feeling to what you've had experienced before? And so on and so forth. Is it new? Is it old? Is it reoccurring? What is it that they could have that could be corresponding to their main complaint is what you're going to start getting at for the secondary assessment. And the good thing is, especially with like a lot of the cardiovascular questions, you can change them for pulmonary as well, along with neurological. So that's just like I said, you start getting into your more in-depth questions because you covered the bases now in regards to you figure out what the problem is. You're starting to get the picture, the jaundiced picture of what's going on. Now you have to start playing the more of the detective work and figure out, okay, is this new? Is this old? Is this something that needs to be treated now or later? What else can we ask so that we can continue our care, not just sit there twiddling our thumbs? And this applies to cardiovascular, pulmonary, neurological, musculoskeletal, integumentary, GI, GU, reproductive, psychological, and social. Those are pretty much every body system or body part that you can think of, because especially like your emotional, it gets into your psychological and social, and usually especially for like your drug overdoses in themselves, that kind of falls into the neurological section of care because it's affecting them neurologically, such as they're taking a drug that is making them stop breathing. Well, what can you do to reverse that is essentially. It also falls into the pulmonary as well, so like how would you treat their lack of breathing? So this is where you start to leave your little box that we have as EMS providers in regards to what is what else can we ask, basically? So now you start taking your vital signs. So you take your full set of vital signs. So that includes your blood pressure, your pulse, and your respiratory rate and quality. Those are your big three ones, especially as the EMR, MFR, that you have to do during your assessment. And either you're going to have someone that you'll either take a set of vital signs on for practice purposes to show your proctor that you are able to take a full set of vital signs. You're going to show how, or you're going to ask, what's my blood pressure, what's my pulse rate, and what's my respiratory rate and quality. But you have to hit each one of those points, because that falls into your vital signs, and without one, you don't have a full set, and you could be missing the big picture. Such as you could have normal blood pressure and pulse rate, but they might be slow respiratory rate or fast respiratory rate. So you got to be really careful about making sure that you get all of your vital signs. So now here is what you also, this is a very important point for your entire assessment now. So this is where you're going to state your field impression of the patient. So what are your final thoughts on what is going on with the patient after everything that you assessed so far to this point? And you have to say that. So once you do your vital signs, you're going to say to your proctor, say, okay, my field impression of my patient is I believe they're having a cardiovascular or a chest pain emergency. And you can explain further why with your interventions, or just kind of tell them, here's why I think that, because of XYZ, here's what they're complaining of, here's my findings as well. So they are having a cardiovascular emergency, just to keep going off of the chest pain example. So remember that is a very important thing that you have to do. State your field impression of the patient, and you have to tell the proctor that. So do not forget that step. Then here you're going to start your interventions, especially if you haven't done any interventions yet for your patient. And this isn't just taking vital signs. This is also known as your last chance for a lot of different things. So here you're either going to verbalize or place what interventions you would do for your patient after you figure out what is wrong with them. So this is your last chance to apply oxygen, depending on the call that you have here. Such as if they may not have warranted it from the get-go, now is your time to put it on last minute, especially if it's a call where they should be on oxygen. Here you're going to start saying that you're going to explain your interventions, such as if you have a chest pain call, you're going to keep monitoring your vital signs. You're going to see if you can help them out with taking aspirin and nitro, because as an EMR, MFR, you can't administer it yourself, but you can find it for them and you can assist them in certain ways. Or if it's a different emergency, such as an anaphylactic reaction, if you have not administered an EpiPen yet, which I really hope you have, especially in the real world, or during your ABCs you did the EpiPen, because that is an airway emergency that will compromise your ABCs if you just let it go, that you give the EpiPen right now. So make sure you list all your interventions and you explain why you're doing them for the call or for the emergency that you are quote-unquote taking care of or assessing. So in reassessment, you're going to demonstrate how and when to reassess the patient to determine changes in condition. So you're going to state how you would reassess the patient and what you would look for. And also you're going to do your trending vital signs as it's worded. And what we mean by trending vital signs is you're going to start doing your repeat vital signs, especially if you have time to do them. Such as if you have a long wait time for an ambulance to come, greater than 15 minutes, you should at least have 2 sets of vital signs on your patient, because they say for a typical emergency call, you take a set of vital signs every 15 minutes for your typical medical call. If it's more serious or more critical, then you start looking at every 5 minutes. And you do those trending vital signs because what you're doing is you're looking for these small changes before a big change that can negatively impact your patient for the worse. So that's why you want to make sure that you keep reevaluating those vital signs and you get your trends, because you're going to start to see where they're at, whether they're going to stay there or get better or get worse. And you're going to verbalize and do what you would actually do for your patient at this point, such as if you're going to reassess your ABCs, you're going to tell their proctor, I'm going to reassess my ABCs, my air, breathing, circulation depth, any changes with their rate, depth, quality, their pulse, how's it feeling, any change in their skin condition. Recheck vital signs, obviously, is one. Any change there? Are my interventions doing what they're supposed to be doing, or are they making it worse for the patient? Are they getting better with them? yes or no. And I would change this if they are not getting better or if they could use more assistance. If they're progressing the right way, but they just need more assistance, you would say, I'm going to change this for this reason. So you have to explain what you're doing to the proctor here. And here you're also going to provide accurate verbal report to the arriving EMS unit. So you're basically going to say to the proctor what you would tell to the high level of care or the ambulance that arrives on your quote-unquote scene, and make it professional, what you actually would tell someone in real life, because I've seen proctors where they get really picky with these, because a lot of people, when they're in their final point of their medical assessment or even trauma assessment, they'll miss something, skip a step, or they'll just breeze through it. Well, they fail because they did not do a thorough enough or accurate enough patient handoff to the higher level of care and the ambulance crew, which ultimately in real life, if you have a finding that you fixed and they got better and you don't tell me, and all of a sudden the patient reverses again because the intervention only lasted so long, then as the ambulance crew, if they have to redo it, now the patient had this twice, they're going to get to the hospital, they're going to tell the doctor, hey, they only had this intervention once. Doctor does his assessment and be like, well, I'm seeing signs that this patient received further care, and the ambulance crew isn't going to know. So now you're going to have that discrepancy between the ambulance and the receiving hospital, and that's just not good, because the patient can actually be doubled up on some care plans and treatments, and that's just not good for them overall sometimes, depending on what it is, such as getting too much medicine, which can lead to an overdose, an indirect overdose, and that's not good for patients. So make sure that you do document and you tell the arriving EMS unit what you did thoroughly. And that's why I always recommend write everything down. Have a notepad, have some type of piece of paper so that you can write all this down so that someone can chart it and have a way to either give it to the arriving ambulance crew, or it's a carbon copy, or that the arriving ambulance has a chance to look at your notes so that they can remember for themselves. Because as long as they see it and you had it charted and they forget themselves, then that's on them. You did your job as the EMR MFR. So it's always good to write things down, especially for future reference, and especially for when you get to writing your reports. I can't remember everything myself, and I know you guys can't either. That's no big deal. That's okay. That's common human nature. No big deal. So just make sure you write things down. It benefits me. A lot of people write things down, so I know it's a very beneficial tool to do. So now at the end of your assessments, especially your medical assessment here, you're going to hear the question, is there anything else you would like to do? Especially it can be added for your patient, or is there anything else you'd like to do overall? And this is where you, as the clinician at this stage, you will say, no, there is nothing else I'd like to do, or I have done everything I would like to do for the patient, or you're going to start thinking and second guessing yourself, and this is your very, very, very last chance to actually do anything for your patient if you did forget. So this is your saving grace right here, your saving moment, because if you say, no, I am done, or I am complete with assessing my patient, I am complete with the station, however you word it. I know for me, I said, no, I've done everything I'd like to do. That's how I worded it. Once you say that, they go, okay, thank you, and you're done. So be very careful with, especially this end. Utilize it. Take that couple seconds to think about, did you hit every point possible? And that's why I say, when you memorize these sheets, if you just go step by step by step, you'll see it and know it, and you have it memorized. Okay, I hit every point that I have to. And especially your critical criteria that are auto failures, if you memorize the big ones, you know you'll be fine. So that's okay. But you have to tell your proctor, yes, I am complete here. They have to hear that from you after they ask this question. So here, I'm going to take another pause just to kind of prepare for the trauma assessment one. So I think I'll make this into a second video just because of how long these videos are. And I'll get them separately uploaded on a channel here for you guys. So take a break, or I will see you when I do the trauma assessment then.